Welcome to this medicine masterclass on cerebellar disease. The cerebellum contributes to coordination, precision and timing of movement, fine-tunes motor activity, facilitates balance and equilibrium, maintains muscle tone, and is involved in motor learning. The structure of the cerebellum, or translated as little brain, is located at the posterior part of the brain at the level of the pons. It is found inferior to the occipital and temporal lobes and sits within the posterior cranial fossa. It is separated from the cerebral cortex by a dural septa called the tentorium cerebelli. There are three anatomical lobes that can be distinguished in the cerebellum: the anterior lobe, the posterior lobe, and the flocculonodular lobe. These lobes are divided by two fissures, the primary fissure and the posterolateral fissure. In order to examine the cerebellum, start by observing the patient from the end of the bed. In particular, look for any abnormal movements of the limbs or the trunk. Next, examine the eyes. In particular, at extremes of gaze, observe for nystagmus. Examine the patient's speech. You can examine different components of phonation by examining the lips, tongue, and palate separately by asking the patient to make various sounds. The lips can be tested by asking the patient to repeat ba ba ba. The tongue can be assessed by asking the patient to say la la la, which involves tongue movement, and the palate can be tested by asking the patient to repeat the word ka ka ka, which involves the use of the posterior aspect of the tongue on the palate. Or you can ask the patient to say British Constitution, which uses a variety of oral muscles. Next, move on to examine the arms. Examine the arms, their tone, reflexes, whether there's an intention tremor, whether there's evidence of pass pointing, dystidocalkinesia, or rebound phenomena, and we'll explain these in a moment. In the legs, also examine for tone reflexes and examine the feet for pes cavus, a young patient wheelchair-bound with cerebellar signs associated with visual and hearing loss, as well as upper and motor neuron signs, may have an autosomal recessive condition called Friedreich's ataxia. This is a condition which affects the FXN gene on chromosome 9, leading to defective frataxin. Also examine the patient's gait. Observe them standing with their feet together, perform Romberg's test to distinguish cerebellar disease from sensory ataxia, and observe them walk. If they veer towards one side, then that would suggest the side of the lesion. Also observe tandem gait. That's a heel-to-toe gait. Romberg's test is not for cerebellar disease. It's to test for sensory ataxia or loss of proprioception. Naturally, sensory ataxia and sensory disease will be worsened with the eyes closed due to loss of further sensory stimulation. In cerebellar ataxia, even with the eyes open, the patient will have ataxia, and so the test cannot proceed to the second stage by asking them to close their eyes. Therefore, Romberg's positive does not really apply to cerebellar ataxia. Let's go through the key signs that you're expected to pick up. Danish is a common mnemonic. Dystidocalkinesia, ataxia, nystagmus, intention tremor, slurred speech, and hypertonia are the cardinal signs of cerebellar disease. Patients may also have additional signs such as dysynergia, where simple movements are broken up, titubation, which is head nodding and irregular movements, rebound phenomena, where the patient's unable to resist strong contraction on removal of resistance, absent or pendular reflexes, and pass pointing. Dystidocalkinesia is the impairment of rapidly alternating movements. Ataxia, the patient veers towards the side of the lesion. And be aware that gait ataxia, when the patient is unable to tandem gait, is usually a defect in the anterior cerebellar lobe. Truncal ataxia, where the patient appears to have a drunken gait with titubation, is usually due to a defect of the posterior or flocculonodular lobe. Limb ataxia, where the upper limbs are usually affected more than the lower limbs with hypertonia, is due to damage in the cerebellum laterally. Nystagmus, coarse horizontal nystagmus, is usually seen with lateral cerebellar lesions and directed towards the side of the lesion. Intention tremor, this is a tremor which is brought on by a purposeful movement. The patient may have Scanning halty, jerky speech, suggestive of bilateral cerebellar lesions. Tone is often reduced and hypertonic in cerebellar disease. Dysynergia is the breaking up of movements, and rebound phenomena. If you ask the patient to keep their arms stretched out and you push their arms down, you'll notice that when the arms come back up, they are in a higher exaggerated position due to the inability to arrest that strong contraction. And this is also called the Holmes rebound phenomena. Reflexes are either pendular or absent, and there is marked dysmetria or past pointing. You can also offer to perform fundoscopy to look for optic atrophy, as demyelination is a common cause of cerebellar syndrome. It's important, if you find cerebellar signs, to think about what additional clinical signs you can elicit to help determine the etiology. Demyelinating conditions, such as multiple sclerosis, would present along with intranuclear ophthalmoplegia, a relevant afferent pupillary defect, upper motor neuron weakness, or sensory disturbance. If the patient has a paraneoplastic cause for their cerebellar disease, examine for signs of cancer, such as cachexia, clubbing, tar staining, to suggest a neoplastic cause. If the patient has had a stroke or a space-occupying lesion, assess weakness as well as the visual field defects. If you think there's a defect at the cerebellar-pontine angle, assess the cranial nerves, in particular 5, 7, and 8. Moreover, additional tests include examining for Parkinson's disease. Multiple system atrophy is the combination of Parkinsonism, bradykinesia, rigidity, and tremor, along with cerebellar signs. Phenytoin use can damage the cerebellum, so look for gum hypertrophy, which may suggest use of this drug. Friedreich's ataxia results in cerebellar signs along with pes cavus. Lateral medullary syndrome, which is a stroke caused by damage to the posterior inferior cerebellar artery, will result in a constellation of symptoms, including ipsilateral loss of pain and temperature sensation in the face, contralateral loss of pain and temperature in the body, and ipsilateral hoarness, as well as cerebellar signs such as vomiting, vertigo, nystagmus, and palatal myoclonus. And just to distinguish cerebellar and sensory ataxia, cerebellar ataxia results from disease of the cerebellum, where sensory ataxia is a defect in the dorsal columns. The deep tendon reflexes become pendular in cerebellar disease and are decreased in sensory ataxia. Sensation is preserved in cerebellar ataxia and decreased or absent in sensory ataxia. Sphincters are usually normal in cerebellar disease, but due to altered sensation, patients can have overflowing continence with sensory ataxia. Remember that sensory ataxia is made much worse with the eyes closed. How do you manage patients with cerebellar disease? If it's a stroke, emergent management, which would involve neuroimaging and prompt treatment, and a multidisciplinary team would be required, including a neurologist, a stroke physician, physiotherapy and occupational therapy, orthotics, speech and language assessment, social services, and counselling. It's important that an MRI is performed of the brain and the spinal cord, and bloods to rule out other etiologies, including thyroid function studies, copper studies, a paraneoplastic screen, as well as bloods to detect infection and inflammation are tested. Importantly, B12 levels, drug levels for phenytoin, carbamazepine, and lithium, and any other drugs that can affect the cerebellum should be tested for in case the patient has excessive concentrations on board. A lumbar puncture can help determine the presence of oligoclonal bands if you're thinking about a demyelinating condition, and EMG and nerve conduction studies can also help facilitate the diagnosis along with genetic testing. So thank you for attending this masterclass in which we covered cerebellar disease, the case presentation, the common examination questions, the differences between cerebellar ataxia and sensory ataxia, as well as all of the signs, how to investigate and manage this condition. Thank you for attending this medicine masterclass.